Welcome to Clinical Conversations, a Journal Watch podcast for the week ending April 10th. This is podcast number 82. I'm Joe Elia. For links to earlier offerings, go to podcasts.jwatch.org. For a detailed look at what's new in clinical medicine, just aim your browser at jwatch.org. Our conversation this week is with Professor Elizabeth Robb and Sir Brian Jarman about their BMJ paper on using healthcare bundles, or checklists, to improve patient care in London, and here as well. We start with a summary of the week's most important clinical news stories. There's a surprising finding that increasing one's intake of fruits and vegetables offers only a very weak reduction in cancer risk. The research appears in the Journal of the National Cancer Institute. For instance, a 200-gram increase, or about 2 servings, was associated with a 4% reduction in overall cancer risk. Given their beneficial effects on cardiovascular health, though, it's still a good idea to keep fruits and vegetables on your personal menu. Next, more surprising findings, this time from the UK, where it was observed that chlamydia screening doesn't seem to lower the rate of pelvic inflammatory disease in sexually active young women. The one-year study found that almost 150 women would need to be screened for chlamydia, or 13 treated for it, to prevent 1 case of PID over the course of a year. That study appears in BMJ. Next, losartan, the angiotensin receptor blocker marketed as Cozar and Losar, has gone generic. Having received FDA approval, it will be distributed in the U.S. by Teva Pharmaceuticals. No word yet from Teva on our question to them about when it will become available. Next, childhood cancer has long-lasting effects on its survivors, with an average reduction in life expectancy of about 10 years. Also, young women who received chest radiation for their cancers are at substantially elevated risk for breast cancer and thus should start annual surveillance mammography and MRI about 8 years after ending therapy or age 25, whichever comes later. The articles which appear in the Annals of Internal Medicine point to the Children's Oncology Group care guidelines as a good resource for clinicians who treat these survivors as they emerge into the world of adult medicine. And finally this week, a reminder that conflicting economic incentives in medicine are harmful. A JAMA study of Medicare claims finds that the rate of the most complicated surgery for spinal stenosis rose 15-fold over the period 2002 to 2007. The procedure has double the rate of medical complications and double the rate of hospital mortality as simple decompression alone. With no apparent cause for the increased usage, and with surgical reimbursement for the more complex procedure at some 10 times that of simple decompression, eyebrows are now raised. That's the news. Here's this week's conversation. You're listening to Clinical Conversations. Last week, BMJ published an article in its practice series on how a 3-hospital group in northwest London improved its patient care. The hospital group had been stung by some adverse media coverage and decided to use checklists, also called care bundles, to improve care in the 13 diagnoses associated with the most deaths. They designed single-sheet checklists for various conditions, such as stroke, heart failure, and surgical site infections, and made them widely available to the hospital's clinicians. The checklists were all based on standard guidelines used in both the United Kingdom and the United States. In the year after these bundles were introduced, the 13 targeted diagnoses showed significant reductions in causing mortality, and the hospital group as a whole lowered its standardized mortality ratio, and that's a measure of hospital mortality with 100 as the UK average. They lowered that ratio from 90 to 71. We have as our conversational partners today the first 2 authors of that BMJ paper. Professor Elizabeth Robb was the Director of Nursing for the Northwest London Hospitals NHS Trust, and she's a visiting professor at London South Bank University and Chief Executive of the Florence Nightingale Foundation. Sir Brian Jarman is Emeritus Professor at Imperial College, London, and a Senior Fellow at the Institute for Healthcare Improvement here in Cambridge, Massachusetts. Welcome to both of you.
Thank you.
Thank you.
Professor Robb, I was taken with your YouTube lecture that explained the quality improvement, explaining quality improvement in the image that you used of driving a car with only 3 wheels on it. I think that image might resonate well with American audiences. So could you reprise that for us as an explanation of what you were setting out to do?
Yes. One of the things that happens in healthcare, because healthcare now is so complicated, there are a range of things that people can and do in order to improve outcomes for patients. And it was my concept that having visited the Institute of Healthcare Improvement in Cambridge and seen their use of care bundles, that there was the opportunity to develop the concept further, bringing it back to the UK, and producing simple checklists for other conditions, especially the ones that are the highest causes of in-hospital mortality in this country. And the reasoning behind it is that you pick half a dozen or so of the key clinical care that can actually make a difference to the outcome for patients, the ones that have the best evidence. And what happens sometimes is that people miss 1 or 2 of them, or they do 75% of the things that they need to do all of the time. And so I was taken with this analogy that if you go outside to drive your car and you notice that one tire's punctured but the other 3 are working perfectly well, you don't say, well, actually that will get me to work perfectly adequately. And yet in healthcare often we congratulate ourselves that we've done 75% of the things most of the time. So it really demonstrates, I think, the importance of making sure you do all of the clinically important things that make a difference to the outcome all of the time and reduce the variability.
And those care bundles, Sir Brian, were single sheet affairs, weren't they?
Yes, they were, and you can take a sort of peel-off sticky sheet and stick it in the medical notes of every patient that is on with a diagnosis that is covered by one of the care bundles. The basic idea being that the clinicians, particularly sort of young doctors late at night who are very tired, things like that, are required to actually sign off that they've done half a dozen key items for each patient for the optimum care. So it's really almost making the clinicians into automatons. But really, that's what we need to do.
Well, I don't know that would be a popular image for them, but what you're saying is that there are things that if you do...
Yes, actually, if you just do all the things you need to do, about 6 or so, for each of the particular diagnoses, there may be more or less, but then it means that you have you give the patient the best chance of doing well.
And I was just going to add to that, and the important thing is you not only reduce mortality, but for me, the key thing is that you also reduce morbidity. For example, if you're lessening the chance of them getting infection, or you're improving the chance of them rehabilitating well from a stroke, for example, then you're actually reducing the worst effects of the illness, not just the likelihood of death. So it's a twofold improvement, if you like.
And I have in front of me the heart failure care bundle. I'm struck by the fact that it's very analog. With the advent of computerized medical records, I guess you'll have other ways to flag those things in the record, won't you?
Well, the idea, I mean, these could actually be put into a computerized form. A variety of even handheld things beside the bed are possibilities. But at the moment, they are peel-off stickies which are actually stuck in the medical notes for each patient and signed off. But they could, I think, in future be actually computerized and again, you would have to make sure on the computer say no if you haven't done it.
And Professor Robb, you were director of nursing at the Hospitals Trust
Yes.
during the period of this experiment. Did you encounter much resistance? I'm wondering, the biggest problem that a reformer has to overcome, is it inertia or is it lack of information on the harm being done? What was your experience of that?
Yeah. The interesting thing was that we didn't get any resistance at all, which surprised me hugely. But I think there were two things that are really important to making a change. One, we had a really compelling vision, if you like, of what could be done. Because when I came back from the States, having been to IHI, and told all my colleagues, I met with all the clinical directors and all the heads of nursing who wanted some feedback on what we'd done, what I'd been doing. And they were really interested in what we had to say. And the vision that I laid out was that here we could actually reduce significantly avoidable hospital mortality. Now, I've never met a clinician that didn't want to prevent death if they can. So you were preaching to the converted. But the second thing that was really important was it was a fairly simple program. And the third thing, which I think is even probably more important, was introducing a little bit of competitiveness.
Uh-huh.
I've never met clinicians that are not competitive. And and clinicians love data. So what I did was I actually produced the data for all our surrounding hospitals. I think there were 8 in the group at the time. And so nothing too difficult, not finding the best in the UK, but just 8 local hospitals, and showing their data on mortality, using the HSMR data that Brian produced and Dr. Foster. And we found one 6 miles down the road that had a lower mortality rate than we did. At the time, our mortality rate was quite good, but it was lower.
Yes.
And I said, is there any reason we can't actually get there? And they all said, no, absolutely not. There's no reason why we can't get there. So the key things, really, to stop people being inert were a compelling vision and a bit of competitiveness
And
with good data.
And how frequently did you update these competitive clinicians on the results achieved?
Fine. We did it every month. I set up a spread. I didn't, but I designed and they set it up, a spreadsheet that tracked the individual diagnoses each month, so that we could actually start to look at the accumulation of the lives that we were saving as a result of the work that we did.
I see.
And we set ourselves a target at the beginning of the year of what we'd like to achieve. That was to get down to the lowest hospital HSMR. And in fact, we would have needed to save about 200 lives. But a wise old soul in the health service once said to me, never undershoot a target, always overshoot it. Be modest and overshoot it.
Huh.
So we said about 110 lives to save. And the outcome was that we saved 255.
I see. So in the paper itself, you actually give that initial lower target, don't you, of 110 lives saved? So
we do, and that was why. That was me being very modest. Because I thought, if this really doesn't work, then I shall have a lot of egg on my face. But even so, one of the hospitals I visited in America set a target of 200, and I thought it looked as if we were copying them as well. So we went for the lower figure.
Well, good for you. It started working within the first month, didn't it? I mean, we
said in the paper, and I'm sure Brian will add to this, but we said in the paper that it is, of course, entirely possible that the fact that people know that you're measuring things and you're watching it, that things do start to improve. That's the Hawthorne effect that we all know about. But it did start to improve dramatically, and one of the first ones was around infection, around Clostridium difficile, which was a major problem in British hospitals at the time. And it started to have a dramatic effect by having an overall comprehensive program that was dealing with all the things that were relevant to bring it down.
So, Brian, there was a question at the end of the paper in BMJ that I haven't seen the answer to yet. And the question, the reader asked, well, in the following year, Did the rates hold?
Yes, that was a good question. And in fact, not only are they held, but actually they're lower than they were, amazingly.
Really? I'm not surprised.
Yeah, they had a consistent reduction.
I'm not surprised. I made a bet with myself before the call, and I said I wonder what the answer will be, and I said I thought that they would continue to drop just because of the momentum that builds.
That's right. Yeah. Actually, I haven't replied to that rapid response yet because the year of recording the data ends at the end of March, and we monitor the stuff every month, and we're just waiting for the end of March data to come through, and then I'll reply. But I've actually sent a sort of private email to the person who I think actually sent it with the results so far, but I won't put the results onto the BMJ website until I've got the final data. But that's the case. And in fact, I mean, if you look at their trend over a period of 3 years, their number of observed deaths was normally at about 1,400, and the number of expected deaths is a bit above that, and they're now about 600 fewer deaths, actually, than when they started at the beginning of the 3 years, whereas the number of deaths expected has gone up slightly. So it seems to be a very definite reduction, and you don't forget, we monitor this on a patient-by-patient basis, collecting the data every month, and we use QSUM statistical process control charts to indicate when they've reached the point with less than 1 in 100 chance that it's occurred by chance.
The realization that you get on the harm that may have been done, inadvertent as it was, is pretty astonishing that you can save just by being cautious, doing simple things. You can save that many lives in a single set of institutions.
Yeah, I mean, I was quite surprised that it was so dramatic, and, statistically it seemed so clear. And as Liz said, it did start right at the beginning of the month when they introduced it. And within 1 month, for some of the diagnoses and for the overall HSMR, it had reached significant level by the end of the month. And we monitored the preceding year, and there had been no change in any of those diagnoses, no significant change. So it dramatically was shown. And, of course, the other point that we've mentioned is that there's actually 3 hospitals, and the one which used the care bundles most was the one that got the significant change.
That was the Northwick Park.
Northwick Park.
Yeah.
I noticed that St. Mark's and Central Middlesex both increased slightly. Well, Central Middlesex.
They didn't change significantly.
Okay.
But they only used about, between them, only 1/5 of the care bundle, 1/6 of the care bundles, and they represent 40% of the admissions, so they were not using so intensively. The incentive came from Northwick Park, and of course Liz was based at Northwick Park, and having heard Liz, you can understand why people did what they were told.
That's right.
Thank you very much, Brian.
So
she's a lady who knows how to plan things and gets cooperation.
And
I think it's really about helping to drive a program, but being a catalyst and working with people. And I have to say the clinicians were wonderful to work with. They were just, when you said, did you have any inertia? The answer is no. They were all just so keen. In fact, they were emailing me, lots of the clinicians who weren't involved emailed me at the beginning and said, the pediatrician said, can we do some bundles? This sounds so sensible. Can we do some? But it was a question of being able to spread yourself not too thinly, so that we could really concentrate on the key areas at the beginning to make sure the program worked.
So what should a clinician do who's interested in championing an effort like this?
The thing you have to bear in mind is that the care bundles are actually in the paper. And if you go to the web version of the paper, they can download all of the care bundles. Some people have emailed me for them, and they haven't realized that they're actually there within the paper itself, so they could download them.
I see. Yes, they are in the left-hand. They're in the left-hand column of the BMJ presentation.
That's right,
online. Yes.
So it says Web Extra in the top left of the BMJ article, says Web Extra, and of course it's free of charge. The BMJ article, anyone can get it. For certain papers, they allow it, that they consider to be important. They allow it to be free of charge. And so you can just go straight to them and download the care bundles as long as you take the web version. But that's, of course, once you've got them, is only half the thing, is making sure that people implement them. And then the other thing, in terms of actually seeing how well you do, the most useful thing is actually to get the monthly data. And we do have a system in which we would do monthly monitoring of any U.S. hospital free of charge also, and give them their results on the web every month.
Really?
They just need to upload their data to us every month. We do 240 hospitals already.
Is that part of the, what is it, the Dr. Foster?
Well, it's actually Imperial College that does it. I started doing it when I was at Institute of Healthcare Improvement in Cambridge, Massachusetts.
Huh.
And when I came back, I got a grant from the RX Foundation in Boston to allow me to spread it wider in the United States. And so I used the Dr. Foster people to provide the IT aspect of it, and we now offer it, and it will be free of charge until the middle of next year. It's funded until then.
Oh, that's very generous. I will put a link both to British Medical Journal and Professor Robb to your YouTube video, which I greatly enjoyed. And
yeah, I didn't even know I had a video on YouTube.
Yes, I got it from a Dutch website. We do this for all the Dutch hospitals monthly as well. And one of them has one of the people over there has actually put it onto their website, which is called hsmr.nl. And I found it there.
hsmr.nl.
NL, yes. And in fact, there are two clinicians from a Dutch hospital who went to northwest London, had a look at the hospitals, and when they came back to me, they said they were amazed that every one of the doctors washed their hands after seeing patients. They'd never seen anything like that.
Well, we've got ourselves out of the 19th century again.
Well, the interesting thing was that they asked us to visit Holland, and we went to one of the hospitals, which I won't say where it was, but they were having a major problem with C. diff, and they said that they had they'd implemented the C. diff care bundle, and that they were looking for major improvements.
And you don't know what the outcome.
Let's hope it did.
Yeah.
But I mean, going back to your original point, it is worth mentioning that everything that we do is about trying to reduce variability. I'm sure Brian will agree with me. The minute you have a whole range of variability in healthcare, that's when you start to have problems. And this is a system that is designed to try and reduce that variability, so the key things get done every time, consistently. And that is what I believe actually started to make the difference. That focusing people's minds on those really key elements, not the other 27 things you might do, but the key elements, while still doing the other things that you would want to do, but making sure you do the key ones.
Well, that's very good advice. I think I'll end it on that note, unless Sir Brian has something that he wants to add.
No, I agree. Turn us into automatons, us clinicians.
I want to thank both of you for your time with us today.
Hope it goes well, Joe.
Thank you very much.
That's it for this week. You can reach Clinical Conversations at 1-617-440-4374. Earlier podcasts are available at podcasts.jwatch.org, where links for all news stories can also be found. Clinical Conversations executive producer is Adoriano. I'm Joe Elia. Thanks for listening. Join us again next time.